This conference will now be recorded.
Good morning to all. Today class is about the tracheostomy. And first, what is tracheostomy? It is making an opening in the anterior wall of the trachea and converting into a stoma on the skin surface, which is called as tracheostomy. Another term is there, which is called as tracheotomy. It is the opening of the trachea, just creating a hole in the trachea, which is a step in the tracheostomy operation. And what are the functions of the tracheostomy? It creates an alternate pathway for the breathing, or the direct pathway for the breathing, indirectly from the directly from the over the neck, and which improves the alveolar ventilation, because by decreasing the dead space by 30 to 50%, normally the dead space is 150 mm, and it also improves the alveolar ventilation by reducing the resistance to the airflow, which is created by the nasal cavity and the nasopharynx and the oropharynx and the laryngopharynx. And it also protects the airways by using a cover tube against the aspiration of the pharyngeal secretions and the blood. Example, pharyngeal secretions aspiration occurs most commonly in the bulbar palsy or the comatose patients. Uh, and also it permits removal of the tracheobronchial secretions by using a suction cannula passing through the tracheostomy tube. And there can be intermittent, it also useful in the intermittent positive pressure ventilation, who are continuously dependent on the ventilatory mechanical ventilation. And it is also useful to administer the anesthesia in the case of maxillofacial traumas, and also in the trauma of the necks, and also the laryngeal carcinomas, laryngectomy patients. Indications: respiratory obstruction, upper airway obstructions. Examples in the case of upper airway obstructions like supraglottic carcinomas, glottic carcinomas, where we have to go for the tracheostomy directly. And also in the case of retained secretions, where we have to continuously clear the secretions from the lungs or the tracheobronchial tree by using a suction cannula, which can be passed through the tracheostomy tube, and we can suction those secretions directly without any use of the tracheobronchial endoscopy, because previously they used to clear the secretions by using the tracheobronchial endoscopy, which is a cumbersome, and also there can be damage to the tracheobronchial tree during that process. So by using the tracheostomy, we can clear the secretion directly by simply using the suction cannula. Third one is the respiratory insufficiency, where the patient is unable to uh, take the air voluntarily. Example, in the case of abdominal injuries, where the pressure created in the abdomen leads to the elevation of the diaphragm and intake of the air, etc. And also in the case of chest injuries, where the patient can't take ventilation normally, respiration normally. In these cases, we can go for the tracheostomy. These are the indications: respiratory obstruction, retained secretions, and also the respiratory insufficiency. What are the types of tracheostomy? It can be emergency tracheostomy, like we have to go for tracheostomy directly in the emergency setting. In these cases, we can go without any anesthesia or without any local anesthesia directly, as it is an emergency tracheostomy. Or we can apply the local anesthesia there, and we can go for the emergency tracheostomy. Most commonly, the incision is vertical type of incision in the case of emergency tracheostomy, because in the case of vertical incision, uh, there will be minimal damage to the surrounding soft tissues like greater vessels, which are present on either side of the trachea, and also the elective or tranquil tracheostomy, or orderly or routine tracheostomy. These it can be of therapeutic and prophylactic. In the therapeutic, it is mostly to relieve the respiratory obstruction, as I have said previously, and to remove the secretions and give the assisted ventilation. And in the case of prophylactic, it is respiratory obstruction or aspiration of the blood and pharyngeal secretions to remove the secretions from the tracheobronchial tree. Permanent tracheostomy, like in the case of laryngectomy patients, where the indication is mainly due to the laryngeal carcinoma, we go for the laryngectomy. And also in the case of hypopharyngeal carcinomas, that is hypopharyngeal means that cricopharyngeal post-cricoid carcinoma, esophageal carcinoma, upper esophageal carcinomas. We go for laryngopharyngectomy, that is excision of the part of the larynx and also the pharynx. So the airway should be kept directly over the skin. It is called as permanent tracheostomy. And another type is the percutaneous dilatational tracheostomy. It is an ICU procedure where we can do in the bedside without any giving incisions. Another one is the mini tracheostomy, which is also called as cricothyroidectomy. Another one is permanent tracheostomy. Permanent tracheostomy is nothing but it is used for bilateral abductor paralysis because the vocal cords are placed in the midline. So there can be difficulty for the air to pass through this closed glottic area, and we go for permanent tracheostomy in these cases because the patient can't open the vocal cords voluntarily for intake of air. And in the case of laryngeal stenosis, mostly laryngeal stenosis, not in the tracheal stenosis, which is present within the chest cavity, we go for the permanent tracheostomy. And another condition where we go for permanent tracheostomy is the laryngectomy or laryngopharyngectomy, as I have said previously. In this laryngectomy or laryngopharyngectomy, the permanent tracheostomy, the lower tracheal stump, which is stitched to the skin, we have to stitch the lower stump of the trachea to the skin permanently. The tracheostomy can be high, mid, or lower tracheostomy. High tracheostomy is nothing but above the level of the isthmus, that is thyroid isthmus. Isthmus lies over the second, third, and fourth tracheal rings, which violates the first tracheal ring. Because which violates the first tracheal ring, it causes pericarditis subglottic stenosis because the cartilage which can most commonly lead to subglottic stenosis is the cricoid cartilage, because repeated erosion over the cartilage leads to the pericarditis, and it can lead to the granulation tissue formation, and it can lead to the subglottic stenosis. High tracheostomy, it is the only indication is the carcinoma larynx, because in the carcinoma larynx we have to go for laryngectomy, that is removal of part of the larynx, and in those cases we have to preserve whatever the normal tracheal rings are there, we have to preserve. In those cases we can go for high tracheostomy, because anyway we can go for the laryngectomy. Mid tracheostomy, it is the preferred one. It is done through the second or third tracheal rings. First tracheal ring should be kept intact. Isthmus divided or retracted upwards or downwards. We can retract the thyroid isthmus upwards or downwards, or we can divide the isthmus in the midline, and we can apply the sutures on either side of the stumps of the isthmus. Lower tracheostomy, it is below the isthmus level. Trachea is deep at this level, and trachea is close to the several large vessels like innominate artery and brachiocephalic trunk and carotids, common carotids. These are the greater vessels which are present close to the lower tracheostomy area. And also the tracheostomy tube impinges on the suprasternal notch, because when we go for the lower tracheostomy, the tracheostomy tube gets repeatedly impinging onto the suprasternal notch area, which can lead to the pushing of the tracheal lower part of the tracheostomy tube onto the anterior wall of the trachea. And this is the laryngeal anatomy. It is the thyroid cartilage and it is the cricoid cartilage. In between these two is the cricothyroid membrane, where we go for the cricothyroidotomy or the mini tracheostomy. This is the first tracheal ring, this is the second, and this is the third tracheal cartilage. We have to go tracheostomy in the second and third cartilage areas, because when we do tracheostomy in the first tracheal cartilage area, it gets repeatedly impinging onto the cricoid cartilage and leads to pericarditis and leads to subglottic stenosis. Technique: ET tube ventilation is possible before the tracheostomy. Whenever it is possible to go for, whenever it is feasible, we have to go for endotracheal tube intubation before the procedure. It will be easy for the surgeon to go for the tracheostomy directly. Position: supine with pillow under the shoulders and neck extended, puts the trachea forward. Anesthesia, either local or general anesthesia, whatever the surgeon rules. It is the anatomy. These are called strap muscles. Strap muscles consist of sternohyoid, sternothyroid, thyrohyoid. We have to separate these all muscles to we have to pull these muscles laterally, and the trachea can be visualized here. But before that, we have to retract the thyroid isthmus upwards. This is the thyroid isthmus. We have to retract the thyroid isthmus upwards or downwards to create a tracheostomy. These are the steps of the tracheostomy. It is the position. First one is the patient position before the before starting the procedure. You can see that trachea prominence, and then we give the incision, and then we have to separate the layers that like skin, subcutaneous tissue, and then we have to retract the strap muscles laterally. We have to retract these strap muscles laterally, and you can visualize the vessels. We have to either cauterize the vessels, or we can pull them laterally or retract them laterally, and we can visualize the trachea directly after retracting the thyroid isthmus upwards or downwards. You can see this is the area where we have to give tracheal incision. We can give like a cruciate incision or create a stoma or create a flap in the trachea, and this is the final insertion of the tracheostomy. Tracheostomy in infants, it is similar to the adults, but you shouldn't extend the neck too much, because the extension of the neck in an infant or children leads to the pulling of the pleura and also the greater vessels upwards, which can lead to the pneumothorax or the injury to the greater vessels. But only exception is only thing we have to take care of during the tracheostomy in the case of infants is that we have to give simple incision. We shouldn't create any stoma directly. Just incision and retraction of this incision area, and then we have to give the tube directly. Common indications in infants and children. In the case of infants, it is subglottic hemangioma, subglottic stenosis, laryngeal cyst, glottic web, or bilateral vocal cord paralysis. In the case of children, it is acute laryngotracheal bronchitis, that is croup, and epiglottitis and diphtheria. Diphtheria, we can see here the membrane, grayish white membrane, which covers the laryngeal area and leads to the obstruction of the upper airway. And the laryngeal edema, chemical or thermal injuries, like in poisonings or in the case of burns. Any superficial injury to the mucosa can lead to the edema and lead to the laryngeal stenosis. And external laryngeal trauma and prolonged intubation, like in the case of ICU patients or comatose patients. In the juvenile laryngeal papillomatosis, because it is very contagious, we have to go for tracheostomy, because when we go for the surgery, in the case of juvenile laryngeal papillomatosis, we have to clear the papillomas, so it can lead to the stenosis of the laryngeal area. So we have to go for tracheostomy preoperatively. Challenges in infants and children. In infants and children, the trachea is soft and compressible, and there can be recurrent laryngeal nerve injury due to the difficulty in identification of the trachea, because the trachea is soft and compressible. And too much neck extension can pull the structures from the chest into the neck and can lead to the pleura, innominate vessels, and thymus injury, or can lead to the lower tracheostomy, as I have said previously. It can lead to the posterior tracheal wall and esophageal injuries and lead to the tracheoesophageal fistula. Just posterior to the trachea is the esophagus, so it can lead to the tracheoesophageal fistula. And do not excise the trachea, as I have said previously. Only you have to incise the trachea, and selection of tube should be done clearly, because the size of the tube is calculated by using the age of the baby. And antetracheal wall infolding should be prevented while keeping the tube. Post-operative care, a constant supervision of the tube, because the tube may get blocked, and suction of the secretions which are regular suctioning should be done to clear the secretions, and also to prevent the crusting and tracheitis prevention by proper humidification. By using the nasal saline or either humidifier, we can go either way, and in this way the crustings can be prevented. Crust can be removed If at all the crusts are formed, they can be removed by using the few drops of normal saline or ringer lactate instillation every 2 to 3 hours. Acetylcysteine is the mucolytic which can be instilled directly into the trachea, and after waiting for about 10 minutes, we can go for suctioning of the crustings. Tube care, regular tube care should be done, like cleaning of the tube. Decannulation. Prolonged use can lead to the tracheobronchial infections, tracheal ulceration, granulation, stenosis, and scars. Stenosis can lead to the tracheal stenosis, and tracheal tube plugging and closed observation for 24 hours. That is, tracheal tube should be plugged, and the patient should be observed for about 24 hours. If there is no problem for the patient for about 24 hours, tube can be removed then. In the case of children, smaller tubes should be kept initially. Gradually, the tube size should be reduced in the case of children. Plaster applied over the area, and should be observed for about 24 hours again, so that the patient is comfortable or not. In the case of infants or children, decannulate in an OT with equipment by the bedside. Watch the child for several hours for distress, tachycardia, or go to saturation. Unsuccessful cannulation causes in the case of children are persistence of the condition of the tracheostomy, like stenosis, or there can be as I have said previously, in the case of children, it can be symptomatic stenosis or anything. In the case of diphtheria or laryngotracheal bronchitis, epiglottitis, they can lead to the persistence of the condition, and we have to keep the tracheostomy for some time. And granulations below the tube, which can lead to the stenosis in the future, and tracheal edema or subglottic stenosis, and incurving of the tracheal wall, as I have said previously. While keeping the tube, incurving of the anterior wall of the trachea can occur, and tracheomalacia, that is collapse of the trachea, like what we have seen in the case of laryngomalacia. Psychological dependence. Complications, they can be immediate, intermediate, or late. In the case of immediate, hemorrhage, apnea due to the CO2 washout in prolonged vent obstruction. Prolonged obstruction of the upper airways can lead to the CO2 retention, which stimulates the central respiratory center repeatedly. When we create a stoma, the CO2 gets washed out. That is tracheostomy. When we go for the tracheostomy, while creation of the stoma, the CO2 gets washed out suddenly and can lead to the respiratory center depression, and the pneumothorax, and because the pleura can get injured while creating a tracheostomy stoma, and the recurrent laryngeal nerve injury, because the recurrent laryngeal nerves on both sides runs in the tracheoesophageal groove and enters the larynx in the cricothyroid gland, and aspiration of the blood, and esophageal injury. In the case of intermediate, it can be bleeding, like reactionary or secondary, tube displacement. Tube displacement, that is the tube may get displaced outside or into the wrong track. The wrong track means on either side of the trachea. Tube blockage due to the crustings or secretions. Subcutaneous emphysema, because the air gets leaked onto the surrounding soft tissue area and can lead to the accumulation of air in the subcutaneous area or surrounding soft tissues. Tracheitis and tracheobronchitis with crustings, atelectasis and lung abscess, wound infection, and granulations. Late complications are hemorrhage due to the major vessel erosion, laryngeal stenosis, tracheal stenosis, tracheoesophageal fistula, decannulation problems in the case of infants and children, tracheocutaneous fistula persistence, tracheostomy scar. In some, it can lead to the keloid or unsightly scar. Tracheostomy tube erosion, corrosion, and fragments may get the fragments of the tracheostomy tube may get dislodged, and they can lead to the aspiration into the tracheobronchial tube. These are the pictures showing the cricothyroidotomy. You can see on the skin here marked thyroid prominence, and it is the cricoid prominence, and in between these two there is a small depression which is called as cricothyroid membrane. It is the place we have where we have to go for cricothyroidotomy. This is the procedure. We we have to go small incision 1.5 centimeter single horizontal stab incision, and we can go directly for tracheostomy tube placement. But a small size tracheostomy tube should be used in the case of cricothyroid. This is the cricothyroid area. Another one is the percutaneous tracheostomy. In the case of percutaneous tracheostomy, we have to keep one needle. Through this needle, we have to go pass a guide wire, and through this guide wire, you have to pass a cannula. And after cannula insertion, we have to go for dilator insertion, and then we have to go for tracheostomy tube placement. Thank you.